in a long duration of therapy. It is recommended only for diabetic dyslipidemia. No doubt it brings down the triglyceride levels, but there is no cardiovascular outcome data as on today.
Sir, my respectful wishes to Dr. Narasingan, who was my teacher in Stanley, 1985-87, the TR unit.
Okay.
Sir.
So nice
sir,
to see you here. Please.
Sir, diabetics with the normal LDL, can we start a statin early, sir? A normal LDL, normal lipid profile in diabetics. The recommendation from Lipid Association of India, the moment you make a diagnosis of diabetes in an individual, type 2, start statin also simultaneously. That's the recommendation. ADA tells you above the age of 40, you can give it. Between 20 and 39, see whether the patient has got a high cardiovascular risk. Use the calculator in the United States, ACC AHA calculator. Identify whether the patient has got a risk of developing a cardiovascular disease in the next 10 years. If the risk is more than 10, you try to start statin. That's the recommendation from the ADA. Sir, is inclisiran better than the PCSK9, sir? Because that inclisiran, because it's yearly, because we pay our patients they cannot afford the PCSK9 inhibitors.
Yeah.
Why inclisiran? What is your opinion?
It's a very good drug. In addition, I need to tell you that's a recently introduced drug. It is actually stopping it is actually a small interfering RNA which goes and stops the production of PCSK9. So it gives advantages. When compared to PCSK9 inhibitor like avalokimab, alirocumab, inclisiran also has shown good results in the form of reduction of LDL cholesterol. But the reduction of LDL cholesterol is much more with this when compared to this. Maybe about 5 to 6 milligrams lesser. Number one. Number two, in acute coronary syndrome, only avalokimab and alirocumab were tried and not inclisiran. We need to wait for the studies. Patient-centered data that is available with the inclisiran also shows that there is going to be some sort of cardiovascular benefit as per the data available today. Yesterday, FDA has approved inclisiran to treat any patient who is willing to take this particular drug without any complications, without any comorbid conditions. If the fellow wants to take this injection of inclisiran, he should be allowed.
Thank you,
Sir,
sir.
Chandrasekhar sir.
Lecture, sir. But there is no, you are lipid authority, sir. But phenofibrate, in your lecture there is no phenofibrate usage.
The drug has been there with us for the past 5 decades. There is no acceptable cardiovascular outcome. It can be used only in those patients in whom you have more than 500 milligrams of triglyceride, with or without diabetes, to prevent pancreatitis. That's all.
Sir, Chandrasekhar sir. Sir, role of melatonin supplementation for this sleep.
Yeah, melatonin, there are only 2 studies to support its use in insomnia. Mainly we use in certain situations when there is a jet lag, we can use the melatonin, not for the social jet lag, but in patients who have some difficulty in initiating the sleep, where the sleep latency is increased, where we can use. So that is the 2. And number 3 is in pediatric thing, people with neurodegenerative diseases, particularly involving the children and adolescents, we have some trials with melatonin.
Regarding LPA, sir, LPA, I got a couple of patients with a high LPA, 50, 55, 60, and so far I have not seen any problem in them. So will they be likely to get a problem in the years to come by, or there is no other molecule? Right now there is no molecule to treat for LPA.
Yeah, it is a genetic disorder, autosomal dominant type of inheritance. There is a strong family history of coronary artery disease and the premature coronary artery disease or death in the family. Think about LPA as a cause. Try to ask the patient's relatives to go for LPA screening. Okay, if LPA is between 20 to 49, consider this a moderate risk. Above 50, there is a risk. Above 100, definitely risk is there.
In those patients you need to intervene. At present there is no recommendation to treat LPA. The drug that has been tried was the aspirin, can reduce the LPA, but aspirin has got disadvantages in the form of hemorrhagic tendencies, so better not to use it. If you are able to reduce the LDL cholesterol sufficiently with the drugs that are available with you, that itself will take care of the injury that is going to be created by the LPA. Because LDL, when you measure, it not only gives the cholesterol content of LDL, it also gives the cholesterol content of LPA. So reduce that. Statins can increase the initial increase in the LPA, but people say it is only the large buoyant LDL cholesterol which are going up and not the small dense LDL cholesterol. If you have a combination like this, for example, LPA is increased. I had a patient who had myocardial infarction. He came with a stroke later. Till that time I did not do LPA. I wanted him to go for LPA, 185. Acute coronary syndrome. He survived. Gave him all medications, no PCSK9 inhibitor. I told him there is no recommendation from FDA for PCSK9 inhibitor, but I can give you. Please tell me whether I can give you because you have got a atherosclerotic cardiovascular disease in both areas. Can I give it? He could not afford, so I had to stop.
So right now there is no molecule. Right now there is no molecule to address LPA.
Yeah, correct. Perfectly correct.
Excuse me, sir. We had a study telling that if you take inclisiran right from 30 years of age, once inclisiran, sir, inclisiran from 30 years of age once a year, you will not get heart attack. Is it true, sir? Inclisiran from 30 years of age once a year if they take. Those who are having, it was told in some seminar, sir.
I don't think that should be taken as a message.
No, sir, that was told. They are claiming do you have a drug that will prevent diabetes?
No.
The cardiologist was asking the diabetologist. So I'm just inquisitive about it.
No, because it is not at all recommended like that. The drug is not recommended like that.
Yes, sir. Thank you, sir. Sir, to Dr. Chandrasekhar, sir, you were telling about one 46-year-old man, RTA, that microsleep. I didn't catch it. Please kindly explain to me, sir.
Yeah, actually, the patients who are having less duration of the sleep with fragmentation, sleep fragmentation. In the daytime, they may have a microsleep. So somebody is feeling sleepy is different, and they'll sleep for microsleep. Microsleep, by definition, is when sleep intrude into the wakefulness. Somebody is wakeful, but transiently, just for 3 or 4 seconds, they close their eye and sleep, and they wake up. So that's the thing. So somebody is driving. That gentleman was driving and he hit another vehicle. So that is a microsleep that can happen with the people who have sleep fragmentation.
Sir, excuse me, sir. You were telling about the night shifts and the risk of CVD. So what is the remedy for that? Because we cannot ask them to, all of them to take a day shift. So what should be done for them?
So that has to be individualized, because everyone is doing night shift, even the doctors are doing night shift. Somebody is preparing for the examination. They also sleep for they don't sleep for 2 or 3 days and having less sleep kind of thing. So that's becoming a very common thing. For that, changing the job is not the answer. Changing the lifestyle and adopting. Even when they have that night shift, morning they should have an uninterrupted sleep, and they should have the control of the other risk factors. Say for example, they should not indulge in the binge eating, maintain their weight, maintaining optimal control of the blood pressure, other lipid parameters, glycemic parameters. All those things, including the stress management, is more important.
And that
it's not that somebody who is doing night shift, all are at risk of developing some kind of thing.
Okay, but does that reduce the risk of CVD if they compensate it with the day sleep and almost with the diet pattern, good diet pattern and healthy lifestyle?
The thing is the other way around. People who are doing night duty and the next day, if they don't sleep, if they have a fragmented sleep, they are at risk of developing CVD.
Sir, thank you, Dr. Narasimhan sir and Chandrasekhar sir.